I am Corey Ellis, obviously. I am a family practice physician that did primary care sports medicine fellowship. So you won't be seeing the surgical type of stuff, obviously, but we are going to talk about youth-specific upper extremity injuries. The big two is going to basically be little leaguer's shoulder and little leaguer's elbow. We'll talk specifically about those who should hopefully be comfortable in talking to your niece, your nephew, your neighbor's kids, everyone in the neighborhood that's asking you questions about these two type of injuries. And then we'll go over some stuff with some guidelines on overuse, burnout type of stuff for younger individuals. Disclosures, no, I don't have any financial agreements, unfortunately. Objective-wise, so this is what we're going to talk about here. We're going to talk about here with the little leaguer's shoulder and the little leaguer's elbow. We're also then going to try to go through some guidelines, which they will be in the presentation, which I thought maybe would be something useful for your office. Unfortunately, I was late getting this to the staff, so if you do want a copy of this, you can call our office, or you can actually email me. It's just my name, corey.ellis@wright.edu with the W-R-I-G-H-T. And then understanding some concerns about some overuse injuries. First one, little leaguer's shoulder. So a proximal humerus physis injury. The common history that you will see, presented again by a neighbor or someone in your office, is usually a participation in a throwing sport, even though that's not necessary. Pain in the upper arm with throwing. So often at rest, they don't have the pain. It's just with throwing or another type of activity. Peak age is 11 to 14. It's kind of crept down here more recently as younger individuals are playing more and more baseball. And then it's most frequently with male pitchers. Fast pitch softball, it does occur, and we'll talk about the mechanism on how it does occur, or how it differs between those two. Exam-wise, you're going to talk about tenderness to palpation over the proximal humerus. That is going to be often your only sign, in addition to the history that they present with. It's sometimes also basically just squeezing the upper arm, or palpation along the lateral aspect is what you'll notice. The other type of symptoms are findings that are often associated with injury. The swelling, the weakness, the atrophy, all those things listed aren't necessarily going to be seen in this injury. So you've got to have a high index of suspicion, judging by the history with the patient. Risk factors, obviously the age, they have to have an open growth plate. The pitching frequency, how many pitches are they pitching a week? How many games a week would be a factor in that? And then how many months out of the year? Most of the time when I see these, it's not something where it's been just a couple weeks. It's been going on for a couple months. They rest maybe a week or two, get back to pitching. Or they don't pitch for a couple weeks, and then they're back to pitching and they notice that it still hurts. The other thing to consider is other positions played. If they play first base, they're not going to be throwing as much as if they play catcher when they're not pitching. So take that in consideration as well. And then the mechanics, it's tough to get appropriate mechanics in the office, but if you was at your own son's game and you saw how he was pitching, you could make some observations with that, but we didn't necessarily get into specifics with mechanics today. Imaging-wise, so yes, you will do usually an AP X-ray with both internal and external rotation, and what you'll see is on the one side, the most common finding is the widening of the growth plate. On the other side, you just want to use it as a comparison. Again, that's not always the case. Sometimes you'll see some fragmentation or some sclerosis, where you'll see some thickening or some higher density of the bone surrounding that growth plate. Usually, it ossifies by age 17 or 18 in young men, and obviously it won't be a problem after that, or in theory wouldn't be a problem if it was treated appropriately. MRI-wise, generally I try not to get an MRI, because if they're having pain in their shoulder when they're throwing, whether they have the X-ray findings or not, and they're 12 years old, I'd say rest is a good treatment option. Often you will have some patients like, well, I have the most important game of my entire career coming up in 2 weeks, even though I find that hard to believe, but often they'll be like, I need to play, I need to play. In those situations, I'd discuss this problem. I say my preference would be is that you need to rest. But if they need hard evidence that says that there is something wrong with them, I will sometimes do an MRI to present them with some additional evidence that says they have some swelling surrounding their growth plate. So that's where the MRI often comes in. Again, it's swelling surrounding the growth plate. And you can see the white there on the T2 weighted image. There is some swelling within the humerus bone. Mechanism, this is the little ear shoulder. It's thought to be the more of a rotational component. In the late cocking phase, early acceleration phase of throwing, that's where you'd maximally stress that. The difference between the softball pitchers, it's thought to be more of a tractional. Obviously, they're going underhand, so they're not going to have this much rotational component, but more of a repetitive traction of the arm, I guess, pulling on the humerus there. Treatment. The first and biggest, and well, just that alone would be enough to get rid of the pain. Rest, is that's your biggest of all the 5 treatment plans. I tell them it's 1, 2, and 3 is the rest. So they make sure they know that that's the case. Now the duration is often dependent on how long they've had the symptoms, whether they have x-ray findings or not, how wide is it. That would maybe add a little more concern if it is widened or if they have some fragmentation of that growth plate. Commonly a 6 to 12 week period. So the 6 weeks may be more to the point where they're back to throwing but not pitching. 12 weeks or so may be the point where they're back to pitching, even though often I'd say, well, you might as well take some more time. Frequently I say that. Treatment-wise, in addition to the rest, so core strengthening, so when they're not doing anything with their arm, working on their core strength, that would be helpful, especially if they're a pitcher. Then they're going to be also regaining or maintaining their range of motion, working on the rotator cuff and the periscapular stuff. These would be things that you could potentially do with physical therapy. They can have the time and the facilities where they may actually watch them pitch, look at their mechanics, have them bring in a video or take a video of them throwing type of thing where that can be done. So during that rest period, often for the first couple weeks it is just rest, and then sometimes getting into therapy to kind of make their progression back to throwing. The return to throwing with young individuals, I almost always use a stepwise approach. I rarely give a specific time date. Sometimes I'll give times of a minimum, but then go through steps or phases back into throwing. So obviously the pain-free at rest, then I direct the range of motion, then the rotator cuff strengthening when they're actually doing the exercises, that has to be pain-free, and then light tossing, and then non-pitching activities, and then eventual pitching. So at the last one there, when I say consider a break from pitching, those are the situations where if you're 12, you're not going to make your favorite college baseball team as a 12-year-old, but you can eliminate yourself from your favorite college baseball team when you're 12. So I almost always err on the side of rest. If rest is done appropriately, generally they do pretty well without any long-term dysfunction or such. Questions on that portion? I don't know if that was too slow or too fast. We'll keep going. Medial epicondyle apophysitis, or little leaguer's elbow. So little leaguer's elbow is not strictly an irritation or injury to the growth plate, but that's what it's commonly referred to as. There's other associated injuries in that elbow. Generally, pain in the medial side of the elbow is often called little leaguer's elbow, but trying to differentiate what's causing that pain. We'll kind of go through a couple stuff here today. Again, throwing sport, skeletally immature, and this is kind of a wider variety. This is one where the history is frequently more common with someone who's throwing breaking balls, whether it be a curveball, slider, that type of stuff. And Dr. Rubino mentioned earlier, waiting for the breaking pitches till later. This is part of the reason for that. With the elbow, it'd start to be a risk or a history or a common risk factor with that. Exam-wise, here you will see more exam stuff in terms of the swelling, the reduced range of motion, in addition to the palpation with tenderness, or the tenderness with palpation. The risk factors, kind of you can see there, age, same things as with the shoulder, frequency and how much they're pitching. Imaging-wise, it is frequent for this one to commonly have normal x-rays. So again, similar to last time, even if you have a normal x-ray, they're sore on the medial epicondyle, all the other exam stuff checks out, I still have a high, rest or a highly suspicious history, you would still want to consider this. The things that can occur, fragmentation, sclerosis, what we talked about before. Here you can see a fragmentation right there on the medial epicondyle. This is, since we're talking skeletally immature individuals, this is going to be the order of which your ossification centers of the elbow will develop. The reason this is important, we'll talk about in a minute, because we're going to pay attention to when the medial epicondyle ossification center is shows. MRI, again, same type of thing, signal change, what we talked about before. If there is concern about other soft tissue injury, this is where sometimes an MRI comes into play. Again, this picture, you see the swelling right there on the medial epicondyle, the additional fluid change or signal change on the MRI. And this one, incidentally, you see a little bit of a signal change around the proximal UCL there as well, which is the second arrow. All right. This mechanism, in addition to the external rotation of the shoulder that then places a valgus stress on the elbow, and that chronic traction on the medial epicondyle is thought to be the cause. The growth plate is weaker than the surrounding soft tissue in the skeletally immature. That will play a role in an ulnar collateral ligament injury. It would be unusual to have that without having a growth plate injury, just because the growth plate's thought to be weaker. Treatment-wise, similar to what we talked about before, the durations dependent upon how the prior history. This is, again, 8 to 12 weeks of rest or so. This one is maybe not as easy to get back into non-pitching type of activities, because when they swing a bat, that may also cause some pain. So this sometimes takes a little longer just getting back into non-pitching or non-throwing activities. Similar type of stuff before, core strengthening, range of motion. Consider a therapy, especially to help with the mechanics of pitching as well. Returning to throwing, again, a stepwise progression here, going through kind of what we talked about before. I think that gives the patient an idea of what each step is. I like the idea of putting on a minimum, but then saying, okay, I'm not determining when you are going to be back to pitch. It's when your elbow's ready for you to return to pitch, meaning you have to hit each one of these steps. And again, we talk about maybe considering some additional break from pitching. The associated injuries that can occur in addition to the injury to the medial epicondyle growth plate, obviously there is the avulsion type of fracture. So if that growth plate actually breaks and that medial epicondyle gets pulled off the rest of the humerus, that's where those ossification centers come into play. Because if you see the trochlea on the olecranon growth plate centers ossifying, but you don't see the medial epicondyle, well, there's a problem there, meaning that medial epicondyle ossification center is likely avulsed to a spot that you can't see it, or in a different view where you'll be able to see something a little unusual, maybe hiding in the background of the x-ray. UCL sprain or tear, we kind of talked about that as well. That's kind of different. I guess I should say it was previously not considered a youth-specific type of injury, but we're seeing it more and more now with the prolonged pitching and seasons of baseball. And then the ulnar neuritis, what we talked about earlier. Long term, again, if treated well without an actual fracture, no displacement, once their growth plate closes, they do pretty well. So good long-term outcome type of stuff, or you can be optimistic in your treatment here. Questions on the medial epicondyle? Yes?
Do you suspect soft tissue injury much, or is it usually at this point around time that's going to fail away before the tendon or the muscle tendon goes?
I'm trying to think here. Oh, I'm supposed to repeat the question. The question was, do we see soft tissue injuries with more soft tissue injuries or more bony stress-related type of injuries, I'd say more times than not I see the stress-related injuries. The longer that it's been going on, when they said, well, I took off 2 months to play something else or did something else, the longer it's been going on, 8 months, 9 months, then I'm more likely to think more of a chronic soft tissue type of stuff. Did they get their UCL in association with it type of thing? That, and then you kind of use your exam type of stuff to try to differentiate what Dr. Herbenek had mentioned. Where are they hurting? What exam findings do you notice to try to differentiate between the two? Youth pitching. So again, basically a lot of epidemiology that says there's a lot of overuse injuries. USA Baseball, in conjunction with the American Sports Medicine Institute, released some recommendations for young pitchers. So this was the spot, if you have it available, you may want it for your own future reference to keep in the office. This was their recommendations: 9 to 10-year-old pitch counts. So again, per game, per season, per year. The things that I would notice is 50 pitches per game. And if you say, well, that's 5 pitches per batter on average, that's 10 batters, which is not very much. And so if you have a young team playing a lot of games, and then you end up with your 4th pitcher and your 5th pitcher throwing it up against the backstop because they can't throw strikes, and then games last 2 or 3 hours, you can see how there's some pressure to say, okay, we need pitchers that are throwing strikes, you can throw that. So it's not as much as you would think, especially for teams that are having a lot of games. 11, 12-year-old goes up a little bit, 75 pitches per game. And then they're also talking here with 1,000 per season and maybe 3,000 per year. The one thing I'd say about this, in my own personal opinion, I can see recommendations for the year coming down, meaning you can kind of push yourself for that season or kind of come up to the limits, but I wouldn't be surprised to see a year-round type of thing where those limitations going down. Like we see it in our college athletes. Back when I was, well, I shouldn't say, maybe 15, 20 years ago, if you had 2 pitchers on your baseball team that had ulnar collateral ligament surgery, that wouldn't be that unusual. Nowadays, we see 2 per class, 3 per class that end up having UCL surgery. There's some speculation that this was the age that started the trend of, before pitch counts were started, and they're the ones that started the trend of playing 6 months, 9 months. In the winter, you would have pitching lessons and everything else. So there may be some aspect to that. I could see those going down eventually.
Is there somebody that keeps track of their pitches?
For Little League Baseball, there is supposed to be an assigned person keeping track of all the pitches for both teams, where the coach, the umpire, anyone should be able to ask the individual, how many pitches does this person have? So that's kind of the next step. We can kind of go through these youth pitching type of stuff, their recommendations, but we'll get to it. That the Little League does have an assigned person that does keep track. Well, that's the other issue.
They love trying ball, they're good at it, and that's what they do. You watch them and they're doing 400 before they even start.
The other question is about what about non-pitches and how that comes into play, because they're obviously throwing more than each one pitch. Every warm-ups before each inning, whether it be 5 to 7, whether they then move to the outfield and are making throws into second base or what have you. So yes, that is a factor. They haven't necessarily found a good way to measure those. I would say that's probably part of the reason why it seems so low in terms of the numbers. Like if you have a pitcher that may pitch 2.5 innings and then that's it, where coaches or players would be like, well, we're only halfway through the game, how can I have reached my limit already? So that's something that they haven't really got into in terms of identifying or counting those at this point. Again, they're talking about breaking ball pitches, wait until puberty. I didn't necessarily give it an age range, but when they're nearing skeletal maturity or when they're developing greater muscle mass. No returning to a mound, so sometimes if the pitcher, okay, you're pitching, you don't have a few pitches left, we'll put you in the outfield, and then going back to pitching later in the game is now discouraged. Pitching for more than one team, where a player can sometimes, they're not supposed to fudge the rules, but well, they don't know how many I pitched 2 days ago and vice versa. So pitching for more than one team would be discouraged. And then no more than 9 months out of the year for baseball. Again, I could almost see when I recommend patients, I specifically say don't be playing for at least that 3 months. And I also like the idea of playing some other sport that's not related to throwing, whether it be some running sport, basketball, something different I think is a good idea. Here are the Little League rules. You can read through those. We're short on time, but they're in the presentation there. And softball-wise, there is no national softball organization that has come up with pitch count rules that I saw in my research with fast pitch softball. That being said, the StopSportsInjuries.org is an organization that is supported by American Academy of Orthopaedic Surgeons, American Medical Society, different things, different medical societies that have came up with their recommendations for pitch counts. But again, no organizing, sanctioning body has came up with these, but you can read those there. The thing with fast pitch softball is number of pitches. They often have tournaments where they'll pitch 1, 2, sometimes 3 games on a weekend. And so you could pitch 2 games on Friday, 2 games on Saturday, 2 games on Sunday. So they're trying to talk about different days of rest or trying to get rest for the younger pitchers. Questions specifically on the pitching stuff? All right, we're almost there. This is the last section. Overuse injury. So American Medical Society for Sports Medicine, the one I'm biased to because I belong to them, just came up with a position statement on burnout and overuse injuries in youth. Basically what they're talking about with overuse injuries, submaximal loading, repetitive nature of that doesn't allow for soft tissue or muscle or bone adaptation to take place. Risk factors that were associated with that they found was a prior injury. The injuries do seem to be more common during the adolescent growth spurt, so periods of more rapid growth, they are more likely to have overuse type of injuries. So that adolescent time where they are growing 2, 3 inches a year seems, those would be times they are more likely to have an injury. With stress fractures, a prior history of amenorrhea in young women has been associated with future stress fractures. Not necessarily all overuse injuries, just the stress fractures. Here's some examples what they use to try to say, yes, this is a legitimate problem. 16 hours, more than 16 hours in high school athletes had an increased risk of an injury. The 9 to 14-year-old pitchers that did more than 100 innings a year were 3.5 times more likely to have an injury that resulted in lost time. And then the wrist pain, when you try to graph that out for gymnasts, the training intensity and the duration are associated with increasing risk of wrist pain. Early specialization, which is another question now. It seems like every sport wants your 9-year-old to start playing that sport year-round. And so that is a little bit of a concern, meaning this early specialization. A relationship between specialization and early specialization and injury has not been well established, but I'd also say it probably hasn't been well studied yet. A lot of those things are ongoing on whether those mean long-term type of issues down the road. There's also some debate. Well, the people that say there's early specialization, it helps down the line. There would be others that would say developing other skills will lead to a better outcome in the future, or developing elite skills. My personal opinion is how I describe it this way to patients, saying, yes, if you played baseball year-round, your 12-year-old would be better than another 12-year-old that plays 6 months out of the year. But that doesn't necessarily make him a better 16-year-old player or an 18-year-old player. And I'd almost venture to say you're more likely, and if there's some potential that they would be more likely to be an injured 16-year-old player or more likely to be an injured 18-year-old player. So that hasn't been well established, but that's kind of the concern. Early specialization, the studies do show that they are more likely to withdraw from their sport due to injury or burnout, meaning they just don't like it anymore. There's a couple questions they use to identify that. So not necessarily more injuries, but they're more likely to withdraw because of those. They also test swimmers on the national team. The ones that had specialized earlier are more likely to quit sooner and retire sooner. Burnout, just a couple things on overreaching, basically overtraining, training too much where your performance actually declines. There's the functional, meaning they are able to continue to participate. Non-functional, where they start to notice some additional stress. Their decreased performance is a little more difficult to get rid of. It's not just a week of rest or 2 weeks of rest. And then overtraining syndrome, kind of that, an extreme version of the overreaching, meaning their performance has declined for a significant period of time. So often you may not see these patients in your office, but your neighbor will talk to you about their son or their daughter, or your niece or nephew will have some stuff where, okay, they're not just, their 1 mile time is really decreased over the past what have you, even though they're training harder, and then they train harder, and it decreases more. Train harder, and they slow more. And so that would be something to pay attention to with the overtraining syndrome. Again, the burnout type of stuff, or the exact definition of that, saying that they cease their participation in a previously enjoyable activity. Here are some of the risk factors associated with that, some of the stuff you can expect, the training volumes, the demands, different types of coaching, negative performance type of stuff would all be more likely to lead to burnout. The personality stuff was interesting. A few of the first ones were my son, so I was kind of worried writing these down. But perfectionism, need to please others, non-assertiveness stuff. So things where those would be relatively common type of stuff, but then again, things you can do something about, sole focus on their own athletic involvement. So there's things other than one particular sport. So it could be, obviously other stuff, school type of stuff would be the easiest thing to come to mind. Low self-esteem and high stress or anxiety. Their recommendations from this position statement: limit weekly and yearly participation time, limit a sport-specific motion or activity such as pitching if it's the same thing throughout the year, and then the careful monitoring, especially during the adolescent growth spurt. Other terms of ways of prevention: preseason conditioning has been studied somewhat. Now, what they have found, it does reduce injury rates, but these were all in adolescent and pre-adolescent studies. So we don't necessarily say, well, we need 8-year-olds lifting weights type of stuff, but high school age, there is reasonably good evidence that a preseason or training program with strength training, aerobic type of increasing aerobic capacity can prevent overuse injuries specifically. The AAP, the Pediatrics, Sports Medicine and Fitness Council, they talked about strength training and when that can be safe. So if you have someone asking you either in the office, at home, these are a couple of the highlights that they had part of their position statement from the AAP. Avoiding the powerlifting, the max lifts type of stuff, warming up before and after, fluids, and then the big one, making sure it's supervised by someone who's qualified, not necessarily by whatever the coach off the street or what have you. So those can be done appropriately. And that was it. Sources. All right, no, that's the sources. If you need those are on there when we're talking USA Baseball, Little League, that type of stuff. Questions on the presentation stuff? Sorry, we ran a little. Yep. No problem. Thanks, Greg. And then you have just evaluations. You can go ahead and fill them out, hand them back in with Amy back here or Tanya. They'll be happy to give you your certificate to prove you were here, even though I don't know why we need those, but we'll prove you can prove it if someone asks for your certificate. And other than that, thanks for coming.